Welcome guys, today we'll be talking about serous otitis media. It is also known as otitis media with effusion, secretory otitis media, mucoid otitis media, or it is also known as glue ear. We'll talk about that later. Okay, so what is serous otitis media? It is collection of sterile fluid in the middle ear cleft. Okay, whereas in SOM there was infection which led to pus formation in the middle ear cleft. Okay, so serous otitis media is the most common cause of hearing loss in the children. Okay, mind it, it is a bilateral conductive hearing loss in children. So whenever a young patient who is infant or a child presents to you with bilateral hearing loss, then you have to suspect of serous otitis media. But when an older patient presents to you with bilateral hearing loss, then you have to suspect otosclerosis. Okay, bilateral conductive hearing loss in adults, you have to suggest or suspect otosclerosis. We'll talk about that later. Just remember that. Okay. Now, what causes serous otitis media? There are two principal causes. First is decrease in the drainage of fluid produced by the middle ear. Okay, and the most common cause in children is bilateral hypertrophy of adenoid. Okay, then we have eustachian tube dysfunction as seen in cleft palates. Okay, so bilateral hypertrophy in adenoid is seen in children. Okay, and cleft palate. Then we have unilateral nasopharyngeal carcinoma, which is the commonly seen in adults. Okay, then the patient can be suffering from chronic rhinitis or sinusitis as well. It can be also due to chronic tonsillitis. Okay, now the second cause can be due to increased secretory activity of the middle ear cleft. So it can be seen in allergy conditions and also in unresolved ASOM. Okay, if you don't treat the ASOM patient very well and you give antibiotics which are not sufficient, it just suppresses the infection. It doesn't cure it. So how does a patient of serous otitis media presents to you? So what are the symptoms? They will have a mild hearing loss, okay, and it is not more than 40 decibel, and there would be delayed and defective speech because there is hearing loss. Okay, and hearing is a very important part of the speech function, speech development. If there is no hearing, then there will be defective speech. Okay, and there can also be mild hearing. Okay, now what do you find on otoscopic examination? The tympanic membrane appears to be dull, retracted. Okay, retracted, and you can see fluid level and air bubbles. Okay, you can see the fluid level like that, and there would be air bubbles. Okay, especially or when you do Valsalva maneuver and all. Okay, you can see air bubbles. Okay, and we call it glue ear because there is precipitation of fluid inside the tympanic membrane, and it becomes very sticky. It looks very sticky, so it is called as glue ear. Okay, there is also a bluish tinge of the tympanic membrane. Okay, now what are the features of tympanic membrane? As I told you that there is retracted tympanic membrane in serous otitis media, but how do you know that tympanic membrane is retracted? Okay, now when you see the tympanic membrane, it will appear something like this. Okay, this is the right tympanic membrane. Okay, there is the normal cone of light. Okay, everything appears normal, but when the tympanic membrane is retracted, you get a prominent lateral process of the malleus. Okay, it looks like it is going to just come out. Okay, and the cone of light is distorted. It is not like this very beautiful one. It's just distorted. Okay, the handle of malleus is foreshortened, and there is sickling of the malleolar folds. Okay, the annulus also appears prominent. Okay, so if all these features can be seen on tympanic membrane, then you can say it is a retracted tympanic membrane. Okay, now there are grades of retraction of the tympanic membrane. We are talking about the grade 1. Okay, that's commonly seen in serous otitis media. So we will talk about other grades of retraction in some other video. Now on audiological examination, what do we find? The Reni's is negative, which suggests of conductive hearing loss. Weber's test lateralized to the worse ear. Okay, absolute bone conduction test is normal. Schauberg test is lengthened. On pure tone audiometry, there is AB gap, and it suggests of conductive hearing loss. Okay, on tympanogram, we get a B type of curve, that is a dome-shaped curve, which suggests decrease in both the compliance and the middle ear pressure. Okay, it is characteristic of serous otitis media. So these are the presentation. Now, how do you manage a patient of serous otitis media? So, how do you manage a patient of serous otitis media? Now, there can be medical management and surgical management. First of all, we will go with the medical management. Okay, we will give decongestants, anti-allergics, and steroid nasal spray for about 3 months. Okay, we will give patients medical management for 3 months. If the patient is improving, there is good response, then we don't need to go for surgical management. But after 3 months, if there is no response and the patient is still suffering from serous otitis media, then we go for the surgical response, surgical management, sorry. Okay, so what do we do in surgical management? First of all, you need to do myringotomy with grommet insertion. Okay, we'll talk about that in a second. And you have to do adenoidectomy or tonsillectomy. That is, you have to do the surgery for the causative problem. Okay, now if the eustachian tube was blocked due to adenoid, then we have to do adenoidectomy, and it was due to tonsillitis, then we can go for tonsillectomy. Okay, now we'll talk about myringotomy and grommet insertion. So myringotomy, as the name suggests, you can know tympanic membrane and opening. So we just give a small nick on the tympanic membrane and we let the fluid drain out. Okay, now we prefer radial incision in here. Okay, we give a radial incision in the anterior inferior quadrant of the tympanic membrane, and we insert a grommet inside. So why do we insert a grommet inside the incision, and why do we give a radial incision instead of a curvilinear incision? Okay, now remember, the tympanic membrane has radial fibers. Okay, the fibers of the tympanic membrane are arranged radially. Okay, so if I give a curvilinear incision, it will cut all the fibers and it would be very hard for the tympanic membrane to just patch. Okay, so when I give a radial incision, it is easier for the tympanic membrane to be repaired itself again. Okay, but since it is easy and I just give a radial incision, it may just close back up, right? And there might not be enough drainage of the fluid, and the patient may still suffer from serous otitis media. So we insert a grommet. Okay, it acts as a ventilation tube and it helps in the drainage of the serous fluid. Okay, but in some cases, even after the insertion of grommet, okay, there is persistent serous fluid in the middle ear cleft. Okay, and it is very difficult for the fluid to move out. So in this case, we go for a technique known as beer can technique. Okay, so what do we do in this technique? So as you know, we have already given a radial incision on the anterior inferior part of the tympanic membrane, and there is a grommet insertion already. Okay, after that we have to give an incision on the anterior superior quadrant. Okay, just a small nick. Okay, so what this small nick does is the air enters the middle ear from this small opening, and the air which enters into the middle ear pushes the fluid out through the lower opening, and it increases the fluid output. Okay, so this is known as beer can technique. Okay, so that's about it.